now to introduce a dear colleague, Dr. John Keats, our panel moderator. Dr. Keats serves as the National Senior Medical Director of Affordability and Specialty Partnerships at Cigna. Early in his career, Dr. Keats practiced as an active duty OBGYN in the military and held leadership roles at 2 health and hospital systems in the Southwest. Dr. Keats has been a member of the board of directors at the American College of Obstetrics and Gynecology, ACOG. He served on the ACOG expert work group that developed the 2018 redesigned postpartum care standards and also serves as the co-chair of ACOG's Maternal Mental Health Expert Work Group. He was instrumental in driving the change to update ACOG's position on screening for maternal depression and anxiety. Dr. Keats, we are so thrilled to have you back again at the forum. Thanks again for joining us on the main stage, and welcome John and the full panel to our virtual stage.
Great. Well, thank you very much for that very kind introduction, Joy, and a pleasure. The pleasure is all mine, being able to rejoin one of your forums, having been a participant in the past. And thanks very much for outlining what my small role was in the Presidential Task Force that came up with the concept of the 4th trimester and led to the committee opinion published in May of 2018 by ACOG that's had such an impact. We've been asked to tell everybody who's listening in. I know you have a fantastic audience today of over 300 people. But as I said, as Joy said, I work for Cigna, but I live in Timonium, Maryland. For those who know where that is, it's a suburb just north of Baltimore. So back to my roots in the Northeast after spending time in California and Arizona. So I'm going to go ahead and turn it over to my fellow panelists to allow them to introduce themselves, tell you where they live, and tell you a little bit about their organizations. So I know you just heard from Dr. Joya Creer-Perry, but we'll go ahead and turn to her first to allow her to introduce herself. Joya, if you would.
Well, thank you so much, and what an honor. Thank you, Joy, and the rest of the team at 2020 Mom Forum for inviting me, and I hope you enjoyed the plenary. So I'm Joya Creer-Perry. I'm an OBGYN by training. I'm the founder and president of the National Birth Equity Collaborative. We're about 6 years old, and we work to improve birth outcomes for Black moms and babies. But we also work in other non-centered groups. So we've worked in indigenous communities. We've worked with rural white folks in West Virginia, anywhere that's people are being harmed by oppression. We're there to help. Turns out it works for everybody. So happy to be here. Thank you.
Thank you very much. Ali Kassir, CEO of Robin. Tell us a little bit about yourself and your organization.
Thanks, John. And thank you everyone at 2020 Mom for having me to discuss such an important topic. So my name is Ali Kassir and I'm the founder of Robin. Robin is a maternal health and wellness company. We power prenatal and postpartum virtual care. So we have a network of 200 specialized providers such as lactation consultants, doulas, maternal mental health, and more, as well as a parent community of 75,000 across social media and email. So I started this company so that no parent would feel as alone or confused as I once did on my path to parenthood. Turns out 89% of expecting and new moms feel unsupported by society. And I believe that lack of 4th trimester support is a very big part of that problem. So we at Robin, we recently developed a product that is actually very pertinent to the 4th trimester. So it's a text-based perinatal concierge service. What does that mean? Well, imagine that you're a parent just discharged from the hospital. You can actually directly message with our providers. No app to download, just texting in your urgent moment of need questions. So maybe you can't get your baby to latch properly, or you're questioning, is this baby blues versus postpartum depression? Or you just want to ask someone, is this normal? So not only is it powered by real specialized providers, but we've also created an artificial intelligence component as well that I can kind of talk more about later in the panel. It can even screen for maternal mental health. So our goal is to partner directly with hospitals, health systems, and payers to make this service free for parents. Why would providers and payers foot the bill? Well, payers could save $47 billion a year by incorporating breastfeeding support, maternal mental health treatment, and doula care. So thank you, John.
And thank you very much. Appreciate that. Let's turn to Lauren Elliott from Candlelit Therapy. Lauren.
Hi everyone. Thanks, John. And thanks 2020 Mom for having me and inviting me to be a panelist today. I spent a bulk of my career as a journalist and also spent 4 years working in public health for our health department here where I'm based in New York City. And I've spent the past 2 years as a founder and CEO of Candlelit Therapy. So we're working to make access to culturally competent and responsive mental health care and behavioral health care a reality for Black, Indigenous, and POC birthing parents before, during, and after pregnancy. So really looking to remove opportunities for bias through technology versus replacing the humans that we need who are involved in the process. And I'm really excited and happy to be here and speak to the fourth trimester, the needs for moms in the fourth trimester with you all. Thank you very much.
Thank you. Kristen Tully.
Hi, everyone. It's an honor to be here and in community. I'm connecting with you all from Durham, North Carolina. I'm faculty at the University of North Carolina at Chapel Hill, which is the home of the Fourth Trimester Project. And so I work with a lot of really amazing people at UNC and then with partners. And our UNC team includes Drs. Allison Stubbe, Sarah Verbees, Amelia Gibson, and then also Kimberly Harper and Venus Standard and Suzanne Woodward. And so we try hard to be a part of the solution in transforming the way that new parents are treated. So we think a lot, my training's in medical anthropology. So I'm like, what does it mean to be a human navigating pregnancy, birth, and postpartum? And it's such an opportunity to really demonstrate our love and respect for each other. But it's been too little, too late for too long. So we have a variety of programs that we do and research for action so that, you know, the privilege that I experience, I want to be that to be universally available. And then I want to be part of the solution for the rest. I'm a mom of two. So I'll close out this hello with saying one of the ways we've tried to be helpful is creating a website called newmomhealth.com and a sister site, which is in Spanish, called saludmadre.com. And that's really mom-centered, you know, validating information about postpartum. So hopefully people can have the free access to that beforehand and throughout as helpful. Thank you.
Great, thanks very much. Let's turn to Suzanne Nelson and let her introduce herself. Thank you, Suzanne.
Hi there. I'm so excited to join this amazing panel today for a great discussion. And thank you again to 2020 Mom for putting on this great event. My name is Suzanne Nelson. I live in Indianapolis, Indiana. And for those of you who didn't meet me yesterday, I had the privilege of sharing my twin sister Melissa's story to kick off the second day of the forum. My twin sister and I got pregnant at the same time at the end of 2019. We both gave birth to our first children in September of 2020, 10 days apart. My twin sister suffered from postpartum psychosis, which was undiagnosed and untreated. And unfortunately, she took her own life 1 week after her son was born. I was 17 days postpartum when that happened, and I'm still within the postpartum period. So I'm here today to share Melissa's experience as well as my own experience in the fourth trimester. So thank you all for having me.
Thanks very much. And last, but obviously certainly not least, Dr. Andrea Boudreau, please introduce yourself.
Thank you so much for having me. Thank you to 2020 Mom for inviting me to be here. I'm a medical psychologist and have practiced throughout my career to improve outcomes for mothers and children, specifically as a pediatric psychologist. I shared my story with so many because as a two-time breast cancer survivor, we see so often that people struggle with identifying how to incorporate their mental health, but their physical health is often championed. And so I recall during my battle, it was a battle with breast cancer, having so much support. And so what I hope to share today with the panel, with the audience, and being a part of the panel is just to encourage people to seek the help that they need, talk about integrating one's faith, and how the community can support mental health, as we have not seen, unfortunately, so often in our past. So thank you for having me. I am here today in Washington, D.C., and but have been a native of Houston by way of Louisiana. And so just happy to be here with you all today. Thank you so much.
Great, thank you very much. I really appreciate it. So I was going to start out just by taking a few minutes to talk a little bit about my own experience with the fourth trimester and my involvement with the Presidential Task Force that ACOG put together starting about 3 years ago that resulted in the publication in May of 2018. So maybe it's almost 3.5 years ago because the publication's almost 3 years old, of the ACOG committee opinion on the fourth trimester. And what we came to, so I was invited as a representative of the payor community, being a medical director at Cigna. We have a few folks in leadership positions at ACOG that work for payors, but not too many. And I was privileged to be asked to join that task force to look at this whole issue of the fourth trimester. And what we quickly came to, and I think was very valuable, and I think has been imparted to everybody, is this concept that postpartum care does not consist of a single visit at 6 weeks postpartum, which is, you know, you can look at me, I'm old, right? So when I was in training, that's what it was. It's like, you know, okay, postpartum visit, you give somebody an appointment in 6 weeks, good luck between now and then. We'll see you then. We'll do what is the equivalent really of an annual physical exam. We'll do a pap smear. We'll make sure that your C-section scar or your obstetrical lacerations are healed up, and we'll send you on your way. And that's pretty much what it was. Well, that's really not adequate in so many ways. And so what ACOG's concept of the fourth trimester recognizes, as you know, is that, first of all, 6 weeks postpartum is pretty arbitrary. Okay, people are not completely recovered by any means from almost anything you can name at 6 weeks. That certainly we should think of it as at a minimum of a 12-week process, so literally 3 months, a fourth trimester, which is where that came from. And the idea that it should be a series of visits potentially, but certainly more than one, that addresses a multitude of issues for women beyond just the physical healing of their body from the cesarean birth or vaginal birth that they experienced. So ACOG came up with this recommendation that women should be seen a minimum of once during the first 3 weeks postpartum, and then at least one more time, sometime up to 12 weeks postpartum. But really what that committee opinion and what ACOG has put forward after that is that there are a multitude of issues that need to be addressed. Mental and behavioral health issues, planning for future pregnancies, increased risk perhaps of conditions that occur during pregnancy that put women at increased risk for heart disease in the future, at risk for diabetes in the future, at risk for hypertension in the future. So these are all things that we now have to really be cognizant of as physicians and midwives and other providers of postpartum care, that these are issues that really need to be addressed. What's the payer's role in all this? Well, what I tried to advocate there and what we're trying to look at in Cigna as a company, and I'm not here really to speak for Cigna or promote that the company I just happen to work for as my day job, but what I want to put forward is that I saw and expressed that the idea of the way we pay for obstetrical care in this country is a barrier, okay? Because many of you know that OBGYNs get a global payment. They get one payment after a patient delivers, and that's supposed to cover the prenatal care, the care during labor, the delivery, and then the quote unquote postpartum care, right? Well, okay, someone delivers, the check comes from the insurance company, you sort of have the money in the bank, and you know what, wait, I'm supposed to see this patient 6 weeks from now. Well, you know what, I've already gotten paid for that. And if she doesn't show up in 6 weeks, oh well, it's really, as far as I'm concerned, that's a free visit. I don't want to sound too cynical, but I'm really trying to be honest with everybody on the panel and the audience, that was really kind of how we looked at it, and completely wrong. But I think if we're going to change that, one of the things we need to do is uncouple payment for the fourth trimester from the payment that OBGYNs, midwives, and other family practice OBs, other providers of care get for providing the prenatal and birth care, that we should recognize the fourth trimester as a significant service that deserves to be separately compensated. And frankly, were it to be separately compensated, I think OBGYN physicians and other providers of care would be more diligent in making sure that women attended those visits, that they would come at 2 or 3 weeks postpartum, that they would come back at 12 weeks, that they would engage in these discussions that really are going to be so important for their ongoing health, not only for the current pregnancy, but future pregnancies and their life beyond. So that's just a little taste of my thoughts. We have some very, very talented and engaging people on this panel, so I want to turn it over to them. And I'm going to kind of kick the ball off because I'm just going to be a little bit selfish about it, and someone that I really want to hear from, and I apologize for not having been able to hear her yesterday. But Suzanne, I'm really going to turn to you first, if I may, that as a mother who's in the postpartum period right now, what do you think about the concepts that I just talked about and that ACOG is now promoting, and what things do you think maybe you could have received better from either your providers or from society during this critical period of your life?
Right. Yeah, I definitely agree with that 6-week checkup. That I think is, yeah, a very arbitrary date, and having something much earlier would have, I think, helped so many women, especially my sister. In her case, I think seeing her OB within a couple days after being home could have possibly saved her life. And I didn't even get to see my OB until I think I was 9 weeks postpartum, because it was so hard to fit into her schedule. I know she's very busy, and it was actually ended up only being a telehealth call. I think due to COVID also, I think has affected this as well. But and at that point, my sister had passed away, so it was a very long conversation, a lot of tears, of I'm feeling depressed now. My sister just passed away. It was a very emotional call, and it I think was probably the longest appointment that I'd ever had with my OB, because it was almost like a therapy session. So yeah, I agree with that. And then also something actually that was mentioned in Wednesday's panel on the advancing improvements in care, they talked about creating a postpartum plan while you're pregnant. And because I think there's so much of planning that goes into the actual birth itself, but what about after that? And especially once, that new mom gets home and she's experiencing most likely sleep deprivation, or she's experiencing things like postpartum depression, psychosis, or any kind of mental condition, it's almost too late at that point to have a postpartum plan that your husband, your partner, your family knows what to do in that scenario. So I think getting that plan in place while you're pregnant with your OB or your nurses, to have something set up, like these are the people that I need to call if this happens, this is where I need to go. In my sister's case, our family had no idea really what to do. The first place she went to was the ER, and that was traumatic for her. And then she was taken to a behavioral health clinic where no one around her was experiencing what she was going through. So it was traumatic. So I think having those things in place would be very helpful. And then also an in-home care or a postpartum doula, I think would be so nice, even just as an option for women. Something my mom brought up recently after my sister had passed away is that she thought it was so interesting that my dad, when he got a knee replacement, he was visited for 5 weeks at home, either by an OT, a physical therapist, a nurse, and he wasn't able to be released to outpatient care until that nurse actually signed off. So, why can't something like that be offered for a woman that just gave birth, to answer all these questions that she's having, or for someone, a professional, to maybe see, hey, something's wrong here. So yeah, I think those 3 things really stick out in my mind as something that would have helped me and also my sister. So
that's great. It's so important to have that support system, both in your own home and family, but then also a more attentive care by the health system that you're relying on. Dr. Kristen Tully, I saw you nodding a lot while I was speaking, so I'm going to go ahead and look to you next. I'm so interested in understanding. I know a little bit from Allison Stubbe about the Fourth Trimester Project, but I'd love to hear a little bit more in terms of your reaction to my introduction to Dr. Krier-Perry's presentation, and what tools are being used by the Fourth Trimester Project and by whom, and which ones do you wish were being used more?
Thank you. I think I'm always practically jumping out of my seat, so if I'm nodding, then that's like, and I mean, Suzanne, you must be extremely proud of how brave you are. I just wanted to acknowledge you.
Thank you.
So yeah, I mean, this is a sacred time, and Black women in particular have been saying that and leading in this space. And I'm so fortunate to be continuing to hear that and to understand deeper, and to be thinking together, how to not do more things, but how to do things differently. And so we have on New Mom Health a postpartum planning tool. There's care plans, and then there's also your village, and those ideally would intersect and be complementary with your healthcare team, a part of your true support and a resource, and something that is that ongoing conversation. And I think one of the things I was nodding to with just this whole system, who is the system set up for, and is it payers, and is it billing, and is it for financial reasons? And how can we reimagine systems that are for us? What could be more deserving of true care? And so Dr. Joy, when I listen to you, and I write everything down, and like what you say about the hierarchy of human value, I just kind of sit with that again, because Dr. Sheila Kitzinger said there's a 4th trimester to pregnancy and we neglect it at our peril. And I think that the way that people live this, and how they feel alone, how they are alone, and how they are neglected, and how they're ships passing in the night with their healthcare team, instead of like the attentiveness and the timeliness and like the expertise that's there, and how you have shared decision making around this, and not this patriarchal, so I'm going to be sitting here nodding to all the things. And I'm really excited to continue to learn, and then try to offer things that are useful for transforming this space.
Great, thank you. Dr. Joya Creer-Perry, thank you very much for the inspiring presentation. You heard me talk a little bit about ACOG, and I understand actually you are working with ACOG on this concept of respectful maternity care. So my question for you is, what would the fourth trimester look like, or what should it look like under this whole construct of respectful maternity care if we were successfully able to apply it here in this country?
Yes, thank you, John. I love working with my colleagues at ACOG. It's funny, we get beat up a lot as OBGYNs, and we deserve some of the things we get beat up around, but we're also some pretty cool people. So I do have to say, I appreciate getting to spend some time with you and learning from you today, John. So thank you. And Suzanne, thank you for sharing that beautiful story. I feel like I know your sister because I'm here with you and in community. And we did do you both a disservice and continue to do that. So thank you for helping us to do a better job to make sure that moms get to thrive. And of course, my friend Kristen, what would I do without you? So she didn't say all the great stuff that they're doing. I mean, I feel like one of my favorite things is I get to be a participant in the work of the fourth trimester with Allison and with Kristen and the team. And they're videoing inside of rooms and seeing all the horrible things that we do to patients. That's one of my favorite things to watch, and like dissecting what happens actually in patient care. We've never really done that. I had not seen that as an OB-GYN. I'm just watching it from the other side, like how many times we wake patients up after they have a baby, how often we wait till that end, till they're about to leave, as was mentioned, to even talk about what postpartum, a plan for postpartum. Like you have a newborn, you've just had surgery or a vaginal delivery, and now we're going to talk about postpartum. So we don't do this in a thoughtful manner. So to your question around respectful maternity care, it is a term that's used globally. I mentioned it in my talk a little bit. It's a term that the WHO kind of socialized. And if you were to Google it and look it up, a lot of times people talk about respectful maternity care in low resource settings. So they mean things like, oh, the patients are being physically abused, or they're not getting access to the suture that they deserve, or things like that. But really, the truth is, we know in high income countries, money doesn't make you magically respectful. That so many birthing people are dying because they're just not being listened to. They're not being valued. They're not being heard. We haven't decided to really pay attention to it and focus on birthing. And so we get those outcomes because of that. So we were working with American College of OBGYN for the last 2 years to create what will be the fourth R, I think, or fifth R in their AIM work around respectful maternity care. And we really are looking to see what would it look like to not just look at ending disparities, but proactively undoing racism, undoing gender oppression. Like, what does it look like to treat people with respect, to believe that everyone should be able to thrive in their birthing experience? And so that's the overarching theme of it. We started with some researchers, and right now the researchers at Johns Hopkins are creating a patient-reported experience measure for us, and some questions that we're going to test in different environments that we hope to use in quality improvement, right? Because we know folks are not being heard, not being listened to. So how do we create questions that we can have on a survey in HCAHPS, or even if it's just your regular QI in your labor and delivery, that says, hey, patients say, I'm not trusted, right? And so how do we ensure that they get trusted, that we start trusting them? So we're optimistic that with this kind of new reframing coming from the American College of OBGYN, of us saying we want to work on being on respectful maternity care, we understand that patients, birthing people are not being valued or not being listened to. And so how do we work on being more respectful? That's really the underlying theme. John,
Thanks very much.
Okay, thanks.
Lauren Elliott, I'm sorry, were you not done?
No, you were frozen. Your face is frozen. At least for me, it's frozen.
Oh, all right. Sorry about that. I was going to turn to Lauren Elliott to ask you what resonated most, since we were.
Dr. Keats, try turning off your virtual background. We are having
Dr. Joya, what
connection
resonated most with you about her presentation, and as a Black mother yourself, what you took away most from it, or what spoke to you?
Yeah, I definitely, Yeah, you're chopping, you're chopping, but I definitely caught the question, John. Thank you for asking. Yeah, Dr. Joy Perry's presentation deeply resonated with me and my own personal experience. I
Let's
think
see
about my
how I
birth
can turn off
experience.
my background.
Yeah, I'll just keep going. Definitely, when I think about what respectful maternity care looks like, for me personally, my postpartum was where I really experienced my own trauma. I'd say at 38 weeks, I got an intuition that something was wrong. I didn't know what was wrong, but I had a relatively healthy pregnancy, and at 38 weeks, I was like, something's wrong. I asked my OB-GYN for an ultrasound. Come to find out, my husband and I found out that our son was in distress. What we thought was distress, but what was communicated as, oh, normal, but you will need to get admitted into the hospital. So you will possibly be giving birth today, which was completely, it threw us off completely. We just sat there in silence. That had never happened to us before. My birth story includes an unscheduled C-section, like a C-section that I felt was an emergency. It also includes a resident sharing that, oh, my vitals were fine, so we were going to be discharged after we had just been admitted to the hospital just a few hours ago. Again, like just being repetitive of it not being seen as an emergency, and then us having to say we were not leaving the hospital. It just, so much of the experience feels like you're just being shuffled around and not listened to. And then I ended up having a C-section that I wasn't mentally preparing for, and then getting preeclampsia in postpartum, which I had never had an issue with hypertension previously. So in retrospect, I feel like there were just a gumbo of stress factors that led to that, and then dealing with depression myself. So with cannula therapy, we're looking to kind of be the conduit to prioritize just emotional and mental health challenges, making those more visible for providers. We're looking to work with health plans and providers, but just making those experiences more visible, and really digging deep into what respectful maternity care can look like. Because yeah, your presentation, Dr. Joy Perry, just resonated with me so much, because I was thinking about that time of like how respect just needs to be so central to the experience, and just at a human level of like educating your patient about what preeclampsia means, and what, versus like, oh, you'll be treated in this way. It's like so much of it is a learning experience in real time, and the patient is just kind of left there to process or not process, in my case, those emotions. And then we have luckily, my son is fine. He just turned 3 weeks ago, but in those moments, they were very scary moments, and I didn't know what was going to happen next. And then going into this healthcare system as a Black woman, about the disproportionate rates of maternal mortality and morbidity. So you bring that experience, like you were mentioning in your presentation, we bring that as Black women, that experience and that knowledge into, especially working in public health too, we bring that into these experiences with healthcare, and the tension kind of is already like there when you walk through the door. So it's just a lot to carry. So yeah, that's what your presentation brought up for me personally. Thanks for asking, John.
Joy, did you want to respond to what Lauren said? What your reaction is to that?
Yeah, thank you. I mean, I worked a lot in the New York City Health Department. I don't know if we worked together already, and they're trying to work on respectful maternity care. And I think thinking about your experience, and even to the point of not knowing, like them not acting as if it's an emergency, some of that we're trained to do that, right? Like we're trained to, if I look like it's a panic, then you will panic, is what I believe. So then my job is to always sound and look calm. But so many patients, as I've been on this journey, have said to us, in fact, Charles Johnson, he says his line, at no point did the physician's level of emergency change. His voice didn't change. And so I'm thinking, oh shoot, well, that's what we teach people to do, right? So once again, there's a disconnect from our understanding of what patients need and how we're training people to like, I must stand here and look like a robot, and you must not think that I'm afraid. Meanwhile, I'm like panicking inside, like, oh my God, because I'm a human being too, right? So, I mean, I would love to tell my patients like the next day, like, girl, when you were in the ICU, I was like, please God, can we get to this? But we don't get to show you that our humanness. So that's what also just undoing that. Like, yes, we are nervous. We are afraid. We are worried for you. We are worried with you. We value you. Want this to go well for you. So I on behalf of my fellow colleagues, I apologize for us not getting there yet, but we're trying. We're working on it. We're understanding that although historically we have been told to be very stoic, and we give you information and we must not show any emotion, that's just not working for patients. And they really want to really understand when something's emergent, and they can tell from our body language and what we're doing. That doesn't mean we're incompetent. That means that we understand and value them. And that's what we are having to grapple with as a group of providers, honestly.
Yeah, well, I would certainly say your words resonate with me, Dr. Joy. I've been in that situation that you described many, many times. Dr. Boudreau, Andrea, I'm very curious what your reaction is again to all this, and I know we had a question which you can also touch on, which is that Black moms in general are distrustful of the healthcare system, maybe for some of the reasons that Dr. Joy had just brought up. But I'm very interested to hear your perspective on what Lauren had to say as well.
Thank you so much. I'll tell you, I am fighting back tears listening to the stories, both Lauren and Suzanne. And Dr. Joy, your comment of how we are trained to not show that emotion, and it's the same thing for us. We are trained to not let our patients be scared, and so I'm thankful that I'm in a space now where I can be emotional with my patient and know that they can receive comfort in my being present with them in the moment. When I made the difficult decision to leave practice, it was because I was so fed up with how broken our system is. And hearing these stories puts a face to those challenges. And so when I talk about my decision to leave practice and move into administration, I think of a patient that I got a phone call from the hospital they were in saying they're being discharged because their insurance is running out. You might want to come to be a part of their discharge plan. And so those types of situations have stuck with me. And I said, how do we fix this to make care more accessible and where the patient needs it when they need it? And to add these two stories of people who were not patients of mine, but I can give voice to, this is why we need transformation in how we deliver care. So that's what I'm taking away from this time together, this entire conference. It's just, there have been so many examples of why we have to do the work we do. And those days that I miss patient care, being in this fight for families who have experienced things like this, make sense for me. The distrust is something that I just believe is rooted in so much. We've talked quite a bit about the syphilis study in Tuskegee. I think that's one of the go-to places where we talk about distrust within the African-American community. But it's so much more. It's not being heard when we come into the room. It's being, I can tell my story of being told I was too young to have breast cancer, so don't worry about that lump that you feel. And the gynecologist that I was with at the time, who had been my gynecologist for several years, was also concerned, but my insurance company telling me, don't worry about it, I'm too young. And so to have two experiences, we're fighting with my insurance company to have lost a cousin to breast cancer. That's where the distrust comes from, feeling that we're not heard, we're not valued, and that we don't need the care that's presented. I think it's work that we'll have to do and continue to use our communities, use those voices that are our trust. That's one of the reasons that I did my clinical research in how the church impacts that relationship. How does one's faith, and so you may not have the same faith as I, but how does one's faith impact their desire, their willingness, their ability to seek care, to ask for care? One of the things that I've worked on is working with churches to open that door. So I talk about the mobile mammography units coming onto the church parking lots. How do we get people to be willing to talk about their mental health at church too? So what does going into the spaces where people have trust and partnering with them, how can healthcare do that? So we're not, as we look at COVID, right? People are talking about churches being vaccination sites. What does that mean for us to use those trusted spaces to provide care? So.
I appreciate that. Thank you. So to bring it back a little bit to the original topic, which was the fourth trimester, and these obviously were all very important comments. Let me turn to Ali Kassir and reflect a little bit that your organization, as you described it, part of your role you see is to sort of destigmatize and demystify the right to have a family. And as I, in my remarks said, we know planning for future pregnancies is a big part of the fourth trimester. How do you see your organization's role in that, or what are you trying to advocate for in that space relevant to the fourth trimester of pregnancy?
Yeah, thanks, John. So we call this our 3 Ds. So you mentioned destigmatize, demystify, and then the third one we think about is democratize. And let me break it down in the context of the fourth trimester. So, destigmatize. One of the greatest barriers to parents getting the help they need is still the stigma of asking for help. There's still so much stigma around saying, I'm struggling with my postpartum mental health, or I don't think breastfeeding is right for me and my family. And it feels crazy to say it out loud, but it's true. So that's, one of the first barriers we think about is stigma. Demystify. So, another barrier for parents during the fourth trimester is misinformation or lack of information. Really health literacy and parental education are not where we want them to be as a country to ensure that parents feel empowered to advocate for their own care and their baby's care during the fourth trimester. So, how many of us have been asking our private mommy Facebook groups or our mom, friends, is this normal? Only to be bombarded by maybe uninformed opinions. You're not really talking to the expert. 1 in 4 women don't even have a number to call postpartum. So, COVID really also has only exacerbated this problem because parents are now discharged 24 hours after birth, which is just not enough time to get the verbal education that parents need in postpartum. So, that's kind of barrier number 2 is lack of information, misinformation. And then this last one, democratize. I mean, when we talk to our parent community, whether it's over Instagram or email, they're often citing that the greatest barrier is access. So, think about this in the context of the fourth trimester. So many of the providers, in our network, whether it be doulas, postpartum doulas, lactation consultants, they don't take insurance or they can't accept insurance or, insurance doesn't cover those services. So, there's just a lack of access to this type of support. So that's really kind of where we come up with the 3 Ds is, how do we kind of break down these barriers to get parents this care and that education that's just so vital during the fourth trimester.
And what successes do you see? Are you able to communicate that? Have you been able to make progress, do you think, in this area? Because that's kind of a tall order you just outlined. It's really a societal change.
Yeah. So we have, in terms of destigmatize, we primarily try to do that through content. So we share all different paths to parenthood, all different fertility, pregnancy, and postpartum journeys. And sometimes we'll have millions of people who see a particular, piece of content. So, we're trying to destigmatize, along with all these great organizations as well. Demystify, we put out a $49 virtual childbirth education class for all of the, hospital birthing classes and all those maternity tours that were canceled during COVID. For a lot of patients, that was their only connectivity to their provider or to their birth experience or that plan, that birth plan, that postpartum plan. So we partnered with 15 of our providers in our network to put together a very holistic birth class that includes postpartum planning, that includes maternal mental health, it includes twins and multiples, it includes lactation, it has kind of that full spectrum. So, we're doing our best. And the fourth D, which isn't an official D for Robin, but it probably should be, is defend. And that's, I think, what we're all doing here today is really, defending the right to have a family, defending the right to parenthood, defending, to Dr. Joy's point, defending the right to raise your family in a safe and sustainable way, defending the right to, appropriate and adequate care and support and education. So it is a tall order, but, it's a personal passion, and it's a mission that we love coming every day to work to try and solve.
Great. I was intrigued by something you said, and I'm going to make a comment on it and then throw it open to the panel to see what opinions other people have, which is driven probably by COVID to some degree, but I think maybe its roots go a little bit deeper, is this rushing people out the door after delivery. Obviously, we have laws in this country about minimum postpartum stays, 48 hours for vaginal birth, 96 hours for cesarean birth. But certainly, I still, for those who may not know, I call it my hobby. I still deliver babies as an OB hospitalist at a couple of hospitals in Maryland. And I see this. There's a real rush to get people out the door now, much more so than there was pre-pandemic. And should we be advocating for longer hospital stays? Should we be offering more services? And how do we, to Suzanne's point, how do we make sure when people leave the hospital that they have a support structure in place, whether it's family, whether it's friends, whether it's an ongoing relationship with a doula? And I could see how that could really make the fourth trimester transition easier. So I'm just going to throw that idea out, and I'll ask whoever would like to speak first to respond to that.
I'll speak as a former hospital administrator, because that is something that every day we struggled with, this length of stay and how we manage that, how we manage being able to move the rooms. I'm not an obstetrician, so I won't speak to when it's appropriate for a mother to go home. What I'll say is we have to do better at providing the resources once the mother gets home. So it's not necessarily that the hospital, I worked at a very boutique hospital where we prided ourselves on the experience that a mother would have in our facility. And we had single birthing room, single recovery rooms and postpartum rooms long before many hospitals went to single. And I will say it's not necessarily that it was the hospital stay, but it's getting you the resources you need when you get home. If you stay in the hospital a week, there's still the rest of that child's life and your life that we're neglecting as an industry. And so I don't know that it's, I think there's a balance between not rushing a family out of the hospital. I think of having to step in when there was an issue with the mother and keeping the baby admitted because the baby was ready to be discharged and the mom wasn't, or vice versa. How do you keep those two together before both are ready for discharge? But I think what we have to focus on is really the resources that are available. We started the talk looking at where this 6 weeks came from. And so what resources are available for the mom week 1, day 4, what's there for her? And that's where I think we have such a huge gap that we have to address as an industry. both with our payers, with our providers, with our facilities. We've got to address that across the healthcare industry.
I agree.
I agree with Dr. Boudreau. I would say it's too much to ask parents to absorb everything they need to know in the hospital when they're recovering. They've just gone through this big event, and we hear it all the time from postpartum nurses is that parents need repetition. Like they may need to hear the same thing 3, 4, 5 times to actually let it sink in and realize, okay, this is a very important information for these next 3 months. So I do think it is about how do we bridge the gap between the clinical care that parents are getting at the hospital and the holistic care that they need at home. And unfortunately, that gap is much too big at this point. And that's what we're talking to hospitals about every day who are interested in this concierge, is this exact fact. How do we support parents through telehealth, through digital health tools during this period, so at least somebody's checking in on them, even if it's just through text message. Is it as good as everybody having an in-person home visit with a postpartum doula? Definitely not. It's a diluted experience, right? But it's something, and it's bridging that gap, and it's acting as a triage tool to get people to the appropriate care that they need.
I was just gonna talk a little bit about kind of the history of how we got to here. So when we finally started looking at maternal mortality in the last 10 or 15 years, the assumption for my colleagues, especially high-risk OBGYNs, because we didn't have the data, was that there was something happening at the birth experience. So we spent a lot of energy on hemorrhage, hypertension, like all these things. And that's when the most money is spent on birthing, right? That 48 hours to 96 hours, not the 9 months before or the postpartum. So we really focused a lot on that in-hospital stay. When we actually got the data, it turns out that's not when most people die. That's not even your highest risk period. And so what we haven't been able to do is take this idea that others, like Kristen and others, and Dr. Keats have, Dr. Tilly and Dr. Keats have done around this 4th trimester. Like, how do we have, not just that we need people to stay in the hospital longer, but how do we reimagine how we're supporting birthing people throughout pregnancy and after birth, and not only focusing on the hospital birth event, because that was a flawed thesis. The thesis that if we could just fix the birth event, our maternal mortality numbers would improve. They tried that premise for the last couple of decades, and it didn't work. In fact, our numbers got worse. So until we reimagine what the problem is, until we refocus on, I like to say, part of the reason I say it's racism, not race, is because when you start with race being the risk factor, then your thesis statement is because Black people are broken, we must do these things, right? So if your thesis is because people are dying at birth and birthing, we have to fix all these things around the birth experience. And that's just, that thesis is off. We know the data shows that's not what's happening. So how do we really refocus our efforts to not just extending the amount of time people are in the hospital, which I do think that there's a whole, like how we decide who goes home and what, and the fact that we even had to make a law to make people have to stay in the hospital tells you a lot about how we value women, birthing people, right? Like we have to make a whole law so people can stay in the hospital after having a baby. You don't have a law for knee surgery. Someone mentioned knee surgery. You didn't have to make a law that you can't kick people out after knee surgery. So that's the level of devaluation that we're dealing with when it comes to birthing people. So once we accept that truth, then I think it's easier to then say, okay, then what would we do differently? Not necessarily just say, make another law about making people have to stay for 48 hours, but really fundamentally changing our worldviews around how we think about the birth experience. People want to have babies in birth centers. I know this is totally controversial for half of y'all. People want to have babies at home. Like people are free to birth how they wish. It's their bodies. How do we support them and not say we're hyper-focused on you have to be in the hospital for this many days and do these things? Because that strategy is failing moms, all of us.
Kristen, I think you wanted to make a comment.
Yeah, I mean, hospitals are not places of wellness. And so like this theme of advancing humanity in healthcare, and part of being better humans is being anti-racist. And I think a core part of ACOG's leadership has been moving away from this checklist type approach to authenticity. And we also have a lot to learn and expand from the midwifery model of care. I'll stop there.
Okay, you'll stop there, although I'm sure you could say more.
Well, I just because as an OBGYN, when the midwifery model is a totally different thing. So we're like, wow, wait, so y'all do these, you see the person within 24 hours. We don't do that. So it's just a very different model of thinking about how care would be provided. So thank you for bringing that.
The couplets throughout the continuum, you know, and that's what I think the fourth trimester, the heart of it is this, you know, birth is a point on the continuum of development for the baby. And there's been a, you know, it looks different, like when you're not inside someone and then you're on the outside, but they need you just as much. And it is a bi-directional relationship with the birthing parent and the baby, and things only make sense in relation to each other. So how lactation works, how sleep develops, if you think of them as little individuals that don't, you know, then it doesn't make sense. And that's why we have all these questions. How should we do this? Where should babies be? How often should they feed? But if they were a dyad throughout, and then as of course a part of a family unit and community, then we would ask different questions, and we would, you know, so a lot of the work we do is about co-defining problems, as Dr. Joya, you know, like, let's blow these premises up. And whenever, you know, whenever I get to talk to Allison, and then I'm like, this is revolutionary, you know? And that's what's so exciting. And she talked, I just want to share, this is about mental, you know, this conference. She said to me, and I was in tears, of course, because like, about how when she cares for people, she talks to birthing people like they're the protagonists in their story, as they are. And I'm like, oh, no one has ever talked to me that way. And so like, it isn't just revolutionary in healthcare. This is about society. And we're just focused in on this part of the life course.
You said something that was so critical. If we would shift our narrative away from the sickness. So we're trained to find pathology. And so that's the only thing we look for, is what's the broken thing and how do we fix it? And, you know, in mental health and physical health, that's what we do. That's how insurance companies bill. That's what hospitals are looking for. You're assigned to a unit based on what's wrong with you and what type of person can fix you. And if we shift our view to more of a wellness and a holistic space, that's where we would get the access that we need, because we're looking at a more holistic approach to the person's care, as opposed to this brokenness. And so that's where that 24, 48, whatever the hour is, that's where that comes from. So that's what happened with my patient. You know, you don't need any more care. You only need 6 visits. You only need 8 visits, whatever that arbitrary number is, because it's about fixing something that's broken. And so I think as we shift to wellness and valued care, and about health as opposed to a sickness industry, would see much better outcomes. And I think that would be the same here.
Yeah, I agree with that completely. Don't get me started on midwifery care. I want to give a shout out to all the midwives that are listening. I trained a very long time ago, and I spent 4 years at an academic medical center. I was at UCLA, and then I spent 3 years in the Air Force. And then I moved to Ventura, California, and had the privilege to take call with a group that had 2 midwives. I had never seen a physiological birth without an episiotomy until I started to work with midwives. Now, some people will think that's a shocking statement, but that's how it was. And I learned what a physiological birth looked like from midwives. And some of you may think, hopefully find this hopeful, but I just want to say, as a subject matter expert in obstetrics at a large insurance company like Cigna, we are getting more and more inquiries from employers who recognize, and of course it's economically driven, let's be clear about that, who see we spend a lot of money on birth for healthcare every year. How can we reduce that? And they are asking Cigna, and I'm sure it's happening to our competitors as well, What are we doing to promote midwifery care? What are we doing to promote birthing centers? Because of the data that's coming out now about the improved outcomes, what are we doing to promote doula care, et cetera? So these are things that employers are now interested in, and once the employers become interested in it, I think we're going to see some change. So obviously we're having these active discussions at Cigna on how we're going to respond to these pressures, but I think the work that you all are doing is starting to make a difference, and I think it's terrific. So I just wanted to point that out. So other thoughts about that, or other things that maybe payers or the government through Medicaid or the other financiers of healthcare should be doing to promote these other kinds of delivery systems, and then how that, again, tie that into the fourth trimester too, about how we provide care for women after birth. Someone like to make a comment on that?
I think value-based care is the answer. How we get there, I think, is the work that we're trying to accomplish. So again, if you move away from fee-for-service, where you're paid for every encounter and every test, every visit, but if we are moving or shifting to a system where we're paid for outcomes, and the goal is the person's health, and that's what I think the conversation is. And so when we look at Medicaid, specifically in the fourth trimester, we don't have too many mothers on Medicare. I certainly hope we don't have, that'd be a whole nother story if we had Medicare paying for birth. But Medicaid, that's if there's outcomes and resources for this value-based care. I think commercial payers are also doing value-based care conversations. How do we address care delivery that's not pathology driven? How do we look at specific outcomes? That's where I think, and so when you look at a bundle, right, for birthing, what does that look like? What are some of the things that would need to be included in this bundle? What does that, how do you develop something like that? What happens for someone who is choosing to carry a baby for another family? So we've talked about personal birth experiences, but what happens to that person who is not going to take the child, the baby with them? So there are so many things, but I think if we focus on a system that is rooted in the wellness and health outcome, that's where we'd have a much more robust system. And that's where I think commercial payers and Medicaid should really take a more holistic approach to how they fund and provide resources for care to the providers.
I know Allie wanted to jump in, but I just wanted to respond when you said value-based, because it's one of my pet peeves in the sense of value to whom. I sit in a lot of meetings where as a provider, I hear value-based care, and it's usually payers, CEOs, health insurers, and what's valuable to them. So we've been saying for a long time, what's valuable to patients is less intervention, more birth centers closer to their homes. We cannot get anyone to see, even though we have data that this is valuable to patients, we can't get folks on board to actually invest in it. So I just want us to reimagine even the word value-based care. And when every time you say it, think value to whom and for what? Because it's all kind of people with all kind of values walking in that room when they talk about value-based care. And OB is one of the few fields that already has bundled payments. So every time we start with OB, I can tell you, as it is one of the most feminist, it's the most feminized, like going back to the orthopedic surgery thing we just said, so now we're getting into like Joya's pet peeves. So orthopedic surgeons make more for a knee surgery that takes 20 minutes than we do for 9 months of prenatal care, delivery, and postpartum. So there's a devaluation of women's health in general. So then we start talking about making value-based stuff I'm like, listen, how about what Medicaid and payers need to do is actually value women's health. They underfund chronically. They don't pay for it at all. And so then we get the outcomes. Nobody wants to go into it because it's not sustainable. So when you have an OB making this amount, a midwife making a little bit less, and doulas making nothing, there's not a supportive system for you to actually invest in women's health. So I think what people need is actually investment in women's health writ large. It is deeply underinvested in, from payers, private, public. CEOs will tell you, I lose money on labor and delivery. It's a loss leader. But I don't need to make money on labor and delivery because women are the decision makers for their household. Yeah. They bring their husbands in for knee surgery, their daddies in for heart surgery. And so it doesn't matter that labor and delivery doesn't pay. Well, it does matter because we're dying because you don't value us. So like that's really the core of the devaluation is the core problem to me.
And so let me, from my perspective, so I can't speak to every single payer, but the work that I can say I've been engaged with when I speak to value-based care is around that. How do it's taking people not paying for this fee-for-service where it's your care is based on how many times I can get you in. So when I think about how, historically we've done budgets, even for our health systems, it's been about, I need to have this many, procedures, this many surgeries, this many x-rays, all of those things. And so it's about what is the outcome we need and how do we help you get to that outcome? It's not about you coming into my facility. I want to keep you away as much as I can. So that's the work that I've been engaged with. So I just to clarify that, because I do hear you, that labor and delivery outside of, like I said, working at this boutique hospital, labor and delivery is never where the focus is. It's never the service line that gets the attention from the facility. So I hear you 100%. But when I think where we'll be better is when we have outcomes that are covered, not procedures, not visits.
Agreed.
Right. So I hope that clarifies. But thank you for calling that out.
I was going to hop in here too, just to kind of talk through some barriers we've encountered on the payer side. I think when we talk to payers, sometimes we're talking to kind of the behavioral health team, sometimes we're talking to the physical health team. And I think we all agree here that pregnancy and postpartum is this unique time where behavioral and physical health are very intertwined. And unfortunately, we don't necessarily fit into the perfect box at a payer. I mean, even when you think about all the different modalities we cover, I mean, if you go on our website, we have 14 different modalities, everything from mental health, doula, birth education, infant sleep. So we believe if we're really going to care for parents in a holistic way, we have to kind of offer this multiple modality because so many of them are intertwined. Lactation can be intertwined with mental health. So especially with this concierge product we put together, it's also difficult for kind of payers to put us in a box because are we a digital doula? Are we lactation? Are we mental health? So that's one of the big problems I think we've encountered so far. Definitely we come across, someone in the product innovation group or someone in the value-based care group that gets it, but finding that right decision maker at a payer can be challenging.
Yeah, and I just want to chime in. It seems as though the conversation is getting a bit closer to where we need it to be, where it's more equitable. Payment and funding of outcomes is more equitable. Where there's a clear line of which is something we're looking to do, where there's a way to kind of just that where outcomes is like inherently emphasizing checking in and seeing like, hey, how are you doing? Like, and having like that kind of like stronghold on what the actual progress is, or which I actually like. And then also health plans that have been more diligent about bringing their behavioral health claims process more back in-house because of what Allie's talking about, it being so siloed from the claims piece for the payer side and just from the health system side, it being so siloed where the data's disparate and even the providers sometimes don't even talk to each other. The obstetrics or behavioral health are just sometimes completely two different divisions. It's just something I noticed with the hospital we're working with in Indiana. I totally agree.
Yeah, I think, Allie, I think your points are well taken. Speaking as someone who works for a big health payer, so certainly you have a friend at Cigna with me, and I can certainly help you with some of those ideas. But yeah, this whole idea of payment driving behavior on the physician side, and I love Dr. Joy's concept of value-based payment is valuable for who? I think that's a question that's not asked often enough. We have a few minutes left. Sometimes I know when I've been on a panel, it's like I think of a question I wish the moderator would ask somebody else who's sitting there. So I'm going to just open it up in the last few minutes that we have to say, are there any questions any of you want to ask each other? Because I suspect that that's the case. So please, if any of you wants to jump in, go ahead. Yes, Suzanne, please.
So when I was leaving the hospital so I had a C-section with my daughter, and I was there for about 48 hours. And when I was leaving the hospital, I was given the Edinburgh scale. Mm-hmm. And I filled that out, and I felt like they almost gave it to me while they had almost like this process down of having my husband go out and get the car seat, and I was alone in the room filling out this questionnaire. And that always stuck with me of like, I felt like that was on purpose. And then when the nurse that discharged me came in and to talk about, next steps of things to look for. And there was one little mention of, if you're feeling depressed in any way, you need to call your OB. That was really the only thing that was told to me about experiencing any kind of baby blues or postpartum depression. And so my question, and I hate to put you on the spot, but what is that something that, is that a process that they talk about to have the woman alone in the room to fill that out? Okay.
Yeah. In fact, I fell recently and I was in the ER and my husband left to go get something. They came and asked, I was like, oh, we're doing that thing where you make the person be alone. They want to make sure that you're like not being abused. And so there's this whole thing. I think Dr. Boudreau probably has more information on that. Yeah, but I wanted to ask you, Suzanne, like, what would you tell us as people who are running nonprofits and doing this work? Like, what would you ask of us at this moment? How could we be more helpful for you?
Gosh, it's a great question. I'm still learning so much. I mean, as a new mom and also going through this, still grieving the loss of my sister. So it's still a lot and taking it all in. But I think, oh, geez. My mom is over in the corner.
What'd she say? What did mommy say? Mommy has a question. What did mommy got?
Yes.
Oh, so my mom brought up that I actually experienced mastitis about a week postpartum, and I was I had like 104 fever. I was sleep deprived, and I didn't know what the heck was going on. And actually had my husband call the nurse line because I knew if I started getting, through a phone conversation of trying to get to my doctor or through trying to talk about my experience, what I was going through, I would have just broken down and started crying because I was so upset and just so tired. And he just, thankfully, he's great and had to, explain what was going on. But there's all these things that happen in your postpartum period that just were never told to me or never expressed and I even took virtual baby classes, and it's just, there just was such a lack of that fourth trimester and things that could happen. And I know it's a fine line of not scaring the mom because it's a lot and and not stressing her out. But these things, I think if you knew that, these things could happen, you'd feel more prepared and kind of know what to do. So.
Thank you. I think Dr. Kelly's working on that.
But the framing matters. And so how do you provide anticipatory guidance and normalize these things and signpost it and then also not be overly detailed. And people are individuals and they might like it in different ways. And so it's about access, I think, as we talked about. And I put in here, like, this is about accountability too. How do we make sure that systems aren't harming people? And how do we make sure that they know if things are working or if they're not? I mean, especially when there's such a high turnaround, then like, what do you look at the EHR data a year later? Like, like we have to have like meaningful dashboards and action around that. People need to know and to coordinate.
Absolutely. Otherwise, why administer the Edinburgh? Why offer that if it's going to be data that just is housed in a system somewhere? We have to make this data, we have to optimize and make it appropriate for providing care.
Right. Unfortunately, I think the reality of it is sometimes these postpartum depression scales are administered because the nurse has to check that box off in Epic before they can go to the next page for discharging the patient. So, Suzanne, that's so interesting to me, having been an advocate for making sure that people get tested or questions asked about postpartum depression before they leave, that it's being administered in a way that really is kind of defeating the purpose of the whole thing. So that was very enlightening for me. So thank you for bringing that up. Other questions for each other? I really like that, Suzanne. Thank you very much.
And John, it's Joy Burkhardt. I am back on the main stage with you. I think we're going to wrap up the panel. John, do you have any closing remarks that you would like to make?
I'm very sad. I just thought we were just getting warmed up here. I thought we could keep going.
We could keep going. What a fantastic discussion we've had, and we can schedule a part 2. I think people would be very interested in that. Well, any closing remarks?
Let me just say this has been a great discussion. Thank you. I feel like I have 6 new friends that I will be in touch with after this meeting wraps up. And I really appreciate you and 2020 Mom giving me the opportunity to moderate this panel. And let me thank everybody who participated for all the knowledge and wisdom you've imparted, not only to me, but I think to all the participants. So thank you very much.
Thank you, John, and thank you, Dr. Keats. Thank you, esteemed panel. What a lively discussion. We're so grateful.